We're going to carry on now with another presentation on dissection from Dr. Kasirajan.
Go get him.
Thank you. So my talk is titled, How to Manage Expanding False Lumen both in the acute and the chronic situation. This is specifically related to type B dissection. I won't be talking about type A dissections. So 30% of all type B dissection managed medically, if there's not an immediate indication for a thoracic stent graft, will require a delayed repair. The good thing about thoracic stent graft for type B dissections is about 80% or 90% will remodel with just a small proximal entry point coverage. So it's very important to understand that dissections are not true aneurysms. So even though you leave the false lumen open distally, which we may think is a large retrograde type 1 endoleak, most of these patients will continue to regress, with about 80% of them not requiring any further treatment. So in the acute phase, if you have an acute expansion of the false lumen, we do a short segment coverage, approximately about 15 centimeters. In chronics, I tend to go a little longer. In chronics, when they expand, they typically have multiple reentry points, so we cover from the left common carotid all the way to the celiac. Typically, we treat false lumens in the chronic situation if they're greater than the entire aorta is greater than 5.5. Now, the aorta above the celiac is about 4 centimeters. Typically, just placing thoracic stent grafts doesn't work. Avoid thoracic stent grafts for people with connective tissue disorders. We just spoke about that previously. About 10%, despite placing thoracic stent grafts, approximately will continue to have persistent false lumen filling and enlargement, and this happens mainly in the visceral segment. The question is, how do we address these? So here's some outcome data for type B dissections, look at medical management compared to endovascular compared to open surgery. So endovascular tends to do better than medical management or surgical management. The most important point for length of coverage depends on the reentry points. As shown in the first figure, if there's not multiple reentry points that are noticed, a single proximal coverage usually works. The second picture, again, just covering the distinct thoracic aorta will work. It becomes more complex when you have multiple reentry points in the visceral segment. In acute phase, we tend to just place short segment coverage. This was previously shown. We tend to use the subclavian side branch graft here. This patient had acute enlargement of the false lumen despite medical management in the acute phase. We placed a subclavian side branch graft with a follow-up CAT scan. You can see the false lumen is completely eliminated. And this happens in about 80% of the patients. No further treatment is required. Chronic dissection, again, this patient had just a single reentry point, aneurysmal segment of the distinct thoracic aorta to 6 centimeters. Again, just a coverage from the left subclavian to the celiac took care of that problem. Now, there are various techniques that have been described that include occluders, plugs in the false lumen, the Knickerbocker techniques. And in my experience, the Knickerbocker technique, just to show what that is using a balloon to expand the septum and rupture it, so you kind of get stent graft coverage all the way into the outer wall of the aorta. In my experience in chronic dissections, when you have enlargement of the false lumen, the coils in the Knickerbocker technique will usually only work when they're not needed. So they typically work, if you see all the publications there in thoracic aortas that are very small. That's the only time it works, so I don't use them. Distal reentry tears will result in delayed false lumen enlargement. To really address this, you need to extend stent grafts all the way to the iliac bifurcation. Here's a patient of mine now. The advantage of thoracic stent grafts compared to open repair in these patients is you can stage them. And I tend to stage them out about 6 months each time unless they are symptomatic. And the advantage there, I think, I don't have data to support it, but your risk of paraplegia becomes much less if you tend to stage them. So this patient had a thoracic stent graft placed proximally and then was sent to me. He has 2 major reentry points, one above the celiac and the distinct thoracic aorta. I'm sorry, it's playing pretty fast. And then another large reentry point just at the level of the celiac. So the plan was in this guy, he really needs coverage all the way to the iliac, but I don't cover it acutely. So I would place a thoracic stent graft proximally. So that was his previous graft. You can see a large reentry point just distal to it. So in the second stage, we would cover all the way to the level of the celiac. And that's after placing the thoracic stent graft extending to the level of the celiac artery. You can see we now cover the reentry point of the distinct thoracic aorta. Then I plan to re-image them usually in about 6 months.
So you put a drain in this one?
I don't. I tend to place, we have the same issues. We have had issues with drains, so we tend to place them if we do need them. We are able to get them immediately. We have actually had more complications routinely placing drains than placing drains selectively. I do have neuromonitoring, so we monitor EMGs routinely, and if there's any change, then we place drains in. If they wake up, there's issues, then we place drains in, but we don't routinely place drains. Now this, I've not covered all the way down, just to the level of the celiac. I'm shooting an abdominal iotogram. You can see the large re-entry point on the level of the celiac. So he comes back in 6 months, another CAT scan. So the thoracic segment now looks great, but he has a large re-entry tear again at the visceral segment. So for this, we would place a fenestrated endograft. I have a graft that had a hole for the SMA in the right renal. I'm going to place a stent in the left renal, and I'm going to laser fenestrate that. So here I'm coming from the true lumen across the false lumen into the left renal. That's my stent that's going to be used as a marker for laser fenestration. That's cannulating the SMA through a SMA fenestration, cannulating the right renal through the right renal fenestration, laser fenestrating into the left renal stent. And we place a covered stent once we laser fenestrate into the left renal. And that's the completion. We've extended all the way down to the iliac. He did have a junctional endoleak at the level of the right renal. I let that go as the right renal was rising much lower down. And that's his follow-up CAT scan. You can see the visceral, thoracic segment, visceral segment. So in my opinion, when you have a delayed false lumen enlargement and a chronic dissection, you really need to extend. If it's not a patient with connective tissue disorder, you can treat them endovascularly, but you need to extend them all the way to the iliac bifurcation. And we do them in a staged fashion to decrease the risk of paraplegia. Now here's the most important question. Can we predict if you're able to place stent grafts in the acute situation, we can really avoid all these problems? In the majority of these, 90% will completely thrombose their false lumen. So can we predict who are the people who are going to enlarge their false lumen? And we have some studies, and these are very preliminary data, but I'm going to show you 3D analysis using blood flow hemodynamics. Again, it's very important to understand that dissections are not true aneurysms. Even though you have persistent false lumen distally, you don't need to address it all the way down to where the dissection ends. I won't go through all these details. As the previous speaker said, we don't want to put people to sleep. But we looked at peak velocities and shear stress. Hopefully these interesting images will keep you awake. So we looked at the peak velocity using flow MRIs in the true and the false lumen. Did the same thing with shear stress, looking at shear stress in the true and the false lumen. We have only about 10 patients, so not a large amount of data, but at least in the 10 patients, what we found out is that if the peak velocity and the shear stress are 3 times higher in the false lumen compared to the true lumen, all of them, without doubt, continue to enlarge. So again, this is an ongoing study. We're hoping that we can collect more data to prove which of these patients, to show which of these patients really need acute coverage of their thoracic type B dissection despite not having an immediate indication for stent grafting. So in summary, for acute dissections, if there's enlargement of the false lumen, I do a proximal short segment coverage. That'll solve 90% of the problems. Chronics, we tend to cover from the left common carotid to the SMA. That solves 90% of the problem. If the visceral segment continues to expand, you really need to expand them using fenestrated endografts all the way to the iliac bifurcation. Thank you very much.